It really is my pleasure to be here. This topic is obviously hugely important, especially given the COVID-related drop-off in cancer screenings, which we'll be talking about, of course. And as you say, Dennis, there's so much innovation in this space. And thankfully, we have all of you with us, a terrific panel of experts to help us take a deeper dive into all of these topics. Just want to tell everyone how this event, the next hour, is going to be structured. Bear with me for just a second. We will start with two mini panels. The first one discusses the different barriers that prevent people from being screened and how we can overcome them. The second one focuses on what the future of cancer screening will look like. And then this is followed by two slightly longer debates. The first one is on, can infrastructure keep up with the technological innovations in early diagnosis and cancer screening? And then we've got a final one. And I know this is the most controversial one, but I think it'll be a really great debate. Should we all screen all people for cancer? Now, we want you, the audience, to get involved as much as you want. We've got the Q&A button. We've been doing this for a year and a half. You all know how this works. So do send in your comments, your questions, and I will make sure that I leave enough time at the end of this hour so that we can put your questions to the panelists. Okay, I know we've got a lot of ground to cover, so let's get to it. Let me introduce the speakers for the first panel. Dr. Sam Janes, head of the Respiratory Research Department at UCLH. You already saw Dennis and Dave. Gentlemen, again, thank you so much for taking the time. Sam, let me kick off with you, because from your perspective as a practitioner, what are the main barriers that prevent people from getting screened?
So I think screening for cancer is incredibly difficult. And this really goes right from, having the first idea as a scientist, getting something made that you can test patients with, and then screening trials are incredibly difficult. So we have to have tens of thousands, maybe even hundreds of thousands of people involved in screening trials. It's incredibly difficult to get the evidence that we need for screening. And then I think probably I would say there are three major barriers that come to mind. The first is the infrastructure to deliver the new screening test, whether that be imaging or blood testing. Then you need the expertise, so the people to run imaging machines and read the results. The costs are clearly vital. So really we want screening for cancer to be global and affordable. And then finally, I think what's really interesting is the emotional burden. So we all get worried if we're tested for a cancer, particularly those that think they're most at risk. So I think these are probably the key things for me.
Dennis, what about you?
I mean, one of the key barriers is political, I would say. This has been a key issue. Whether at a political level, there is a decision that will direct the public healthcare system to invest in this. And often with screening, you need 10 to 15 years to highlight, which Sam was indicating as well, to have the evidence there to justify this. Now, there is evidence there in breast, cervical, and colorectal cancers, if I take cancers. And this has been, the question is whether it should be universal. And often this is a political discussion. Whether at the European level, since it's constituted by 27 healthcare systems, whether there should be a mandate at the European level to focus on this. And at the European level, we had the Nelson study that came out, and we had a lot of agreement with the scientific societies to undertake screening, for example, in the area of lung cancer. But often the political will is not there. And often there's more emphasis on prevention, because this seems as more cost-effective mechanism to do it, rather than saying, okay, we have this great technology, how do we invest this in the area of, say, lung cancer? And that has been a key issue, the political investment to tackle this. And one of the barriers has been this political issue, which I have good news to say, is that in the State of the Union speech today, which Commissioner Ursula von der Leyen spoke to, she announced that she will update the Council conclusions from Council recommendations on cancer screening from 2003. So they will be updated in 2022. And this has been one of the key political asks that we've put forward at the European levels, that these council recommendations will be updated. And this takes account of also the relevant, not only about screening in a population-based level, but also the use of molecular diagnostics and the data that will derive from that. So there's more of a structured approach. But the science is there, the innovation is there, so it's not impossible. The question is just the political will to do that.
Yeah, that's a very good point. Let me switch over to you, Dave, because one thing that the two gentlemen haven't mentioned yet is the COVID-related drop-off in screenings. How material was that?
Well, there's certainly been a dramatic impact from COVID in terms of diagnosis of new cancers, and we've been a part of a broad effort with lots of advocacy groups across the globe to really try to raise awareness around the importance of just routine checkups and staying on top of risk factors and making sure that cancer doesn't become collateral damage to the pandemic. I encourage folks to take a look at the efforts that we have around New Normal, Same Cancer. I think that it is incredibly important that we continue to stay vigilant during these times. The importance of really making sure that patients continue to play a role in their own health is so key and so important. And I think that with screening, which is really as much as anything a public health issue, we're talking about dealing with people who are healthy that we need to screen. I think that that advocacy is really key and critical.
We now turn from the state of screening today to what screening will look like in the future. For this discussion, I'm glad we're joined by Ebba Hellas-Juholt, the head of Vision Zero Cancer. She joins us from Stockholm, along with Sir Harpal Singh Kumar, the president of GRAIL Europe. And last but not least, Susan Galbraith, executive vice president of oncology and R&D at AstraZeneca. Again, I want to thank all of you for your time. Susan, let me start with you. What does the future of cancer screening look like?
Well, as you've already heard from the previous panel, there are cancers where we've already got the screening and diagnostic tools in place, so breast cancer, cervical cancer. And we do have good evidence for the benefit of lung cancer screening, although it's not been widely adopted because of some of those political aspects and the infrastructure builds that have been referred to. So those all help to detect patients earlier, understand the type of cancer. But there's a large number of cancers where there aren't any adequate screening tools. Pancreatic cancer, ovarian cancer, esophageal cancer, they all tend to be diagnosed late. And as a result of that, the patients have, a poor outcome at the time of diagnosis. So what we really need is to have a test that can include a broader array of cancers and a broader range of technologies. And the ability to identify patients through a blood-based screening tool is very attractive because it fits in with what Dr. James was referring to as the low-cost and potential global application of something. It could be fitted into the screening regimens that we already have. So having had a blood test, that could be used to make sure that you then use imaging tools which are more expensive and have more infrastructure built for subsequent parts of the cascade of screening. So that might be one way in which we could deliver this more effectively.
Mm-hmm. And let's talk about that, because luckily we've got an executive, a representative of the firm that is working on exactly that, a blood-based test. You've developed that at GRAIL. Sir Harpal, thank you so much for being here. How is your technology a game changer?
Thank you, Carolyn. Well, my comments really follow very much on from what Susan was just saying. We have, depending on how we count them, we have maybe 200 different types of cancer, but actually, depending on which country you live in, only a handful of those are actually screened for now. And if I put that in a UK context, just under 4/5 of all cancer deaths are in types where we don't have a screening test. So the GRAIL technology is really about taking a multi-cancer screening approach. And with our clinical evidence so far, we know we can detect at least 50 different types of cancer, which represent the vast majority of the cancer burden. But the other thing, it is a blood-based test. And so what we would hope to be able to do is through that single blood draw, be able to look for a wide range of cancers. It's perfectly brilliant, frankly, to have the breast and bowel and cervical screening programs that we have in the UK and lung in the US. But We need to go much further than that. And it's not feasible to be thinking about screening for every individual type of cancer separately. The other thing that's really important as we think to the future is how we broaden access. And whilst the existing screening programs have been extremely effective, it's not going to be possible, I don't think, in the near future, if the first test is an imaging test or something that really requires expensive equipment or an expensive and well-trained workforce. And that's where blood-based tests really come in as if you like, the entry point to screening and hopefully the entry point to broader investigations that can move us forward.
Ebba, very briefly, let me bring you in here. There seems to be a lot of new technology that we can be excited about, right?
Definitely. And I think that's really the combination of technologies will be crucial in order to offer screening for everyone who needs it in the future. So I think that to summarize, the future will be about universal access. It has to be the low cost so that it's affordable for the health systems. It has to be safe and easy. And I think we will see a lot through the broad drawing test also, that we can see the screening much more being done at home or perhaps in the community pharmacy. So just as Harper pointed out, that we can then use the more other technologies for further investigations for the accurate diagnosis and treatment later on.
All right, thank you all. We want to continue with our first rapid fire debate. Harpal and Ebba, you stay with me. And if you, members of the audience, if you see anything that you agree, disagree with, if you have any questions for any of the panelists who've joined us so far, well, do send in your questions via the Q&A tool. It is now open. And of course, we will put those questions to the panelists later on at the end of the event.